In this session, we're going to try to focus on managed care. The textbook puts it under the supply side sort of category. Up to this point, we're focused on demand for medical care and so forth. And now there's the supply side, but in reality, managed care is both demand and supply side management. So let's start with the supply side. Essentially, the idea of managed care is to reduce cost of care while maintaining patient outcome. So you don't want quality to suffer as you reduce cost. So the idea is to deliver what you do deliver more effectively or more efficiently, which means in economic terms, if you were to think about it, this is input use, and then here is the output or patient outcome. And if this is your sort of production function, input-output arrangement under current, let's say, fee-for-service arrangement, we want through managed care to get a higher level of output for every resource used to generate better outcome under managed care, and that has led to ideas such as accountable care organization arrangements, meaning that create the whole horizontal integration so that you are from end to end delivery, and so therefore through this integration or consolidation you can manage the entire package, if you will. If the patient is in the hospital and is released to home care or a nursing home, you own the hospital services and you own the home care or nursing home services, and then you have also care that is delivered in the home and so forth. All of these are supposed to be as a part of one integrated arrangement. That's of course necessary as people take responsibility for end-to-end delivery. But then, of course, consolidation and integration has a downside, and that is that it reduces competition. In fact, the government has sued some hospitals for buying up other sort of services in the area, such as nursing homes and home care services, in order to have more control over the entire packaging and pricing and service delivery. And the pushback is that if you want us to have integrated sort of end-to-end, then we need to consolidate. But then, of course, the government says that if you consolidate too much, you reduce number of competitors, and as a result, the consumers suffer. So at the end of the day, what is plaguing the healthcare system in the U.S. More than other countries, similar in terms of industrialized countries, is that essentially we lack guiding principles. The industry, as we know it in the U.S., is riddled with contradiction and sort of hostile relationship. Fee-for-service organizations obviously make money. Fee-for-service make money if they throw everything under the kitchen sink. Some of it, of course, produces better outcomes, but some of it may be marginally beneficial. So the whole economic idea that you have to evaluate marginal product of let's say, service A, given the price of service A and compare that to marginal productivity of the service B, given the price of service B. That usually happens in other industries. It's not happening in the medical care necessarily, because this is required for you to make sure that what you throw in, given what you pay for it, is worth the money and it's contributing to the patient outcome. If you're not being held to the same level of scrutiny, then you may throw in service B that is marginally not very efficient, not very result producing. You charge high prices for it, so you suddenly convolute the whole thing, which again in other industries is not going to be well tolerated. Maybe in some industries, such as, let's say, legal system, you go to a lawyer, they fill out all kinds of forms, some of it totally unnecessary other than the fact that they charge you for it. Or you have the military-industrial complex. They develop all kinds of weapon systems. Some of it are not really effective, but then they charge taxpayers arm and a leg. So there are a number of industries that suffer from this misalignment, and healthcare is one of them. So the idea of a managed care is to say, look, make sure that all these products that you throw in are necessary and effective in determining the patient outcome and so forth, and make sure that the prices you pay are controlled, so therefore you produce better results for less reduced resource use. Of course, this requires maybe attention to preventive care, so that you screen patients in advance, you increase incentives for them to be screened, and so forth. You engage in patient education. But all of those things, if you reduce resource use and so forth, that affects revenue. Because under the fee-for-service, you collect. For more you use, more you charge. But so if you switch to something that you can manage how you produce through efficiency improvement, we've talked about here, when you create this environment, you are to improve productivity, you can reduce average cost. This is a cost model. And then, of course, you improve, in the market model, you improve supply, so that you should be able to deliver more care at the reduced cost, and therefore maybe even reduce prices. But all of that suggests that somebody's not making money if they were in the business, and some people and some organizations need to be caught out of the picture, and that is a very difficult thing to manage, because what do you do when you make money doing stupid thing or unnecessary thing? That's very difficult to manage, and so that's why I say that we are sort of suffering from absence of guiding principles. Everybody wants to behave in this industry similar to others. Profit motive and so forth is going to drive. And of course, the assumption is that the profit motive under competitive environment is supposed to lead to efficiency and benefits to the consumers. However, this assumes a highly competitive industry that forces producers to be efficient, because if they're not, somebody else is more efficient, they reduce their prices, you are out in the cold. And so then high-cost providers, inefficient providers are kicked out, and the consumers will benefit. That's under a very highly competitive environment. The reality is that medical care is not very competitive, and so therefore the assumption that we are going to see the results from this competitive environment is unfortunately not always realized, and so therefore we struggle with how to manage this thing. And then, so right, if the sellers or providers don't have enough incentive, we can create a accountable care organization, HMOs, and then create some kind of a profit sharing, meaning that if they save resources, deliver the outcome with less resource use, reduction in high-tech, expensive technology, so forth, to reduce costs, reduce hospitalization, increase generic drugs and so forth, use of it, preventive care, increasing preventive care, etc. These are all supposed to help out, and then this is all on the supply side, and then we have introduced all sorts of high deductibles and co-insurance, etc., to manage the demand. So this will be the demand when insurance pays for it, all of it, and so forth. You don't ask questions. But this would be less than demand and also more price sensitive through basically high deductibles. Etc. And so this is the managed demand, while we're trying to encourage also managed supply at the same time. And so there's a conflict of interest. People don't want to take care of themselves. There's some responsibility, partly because they're not educated and skilled, and yet they just wait until they need care, and then the providers are really jumping and throw everything in to ring up the charges. So how do you discourage that? And then how do you also prevent them from unnecessarily cutting costs and putting the patient outcome at risk? And we get into this sort of a very strange arrangement. One example that you could think of alternative is family. I mean, imagine that families try to operate like the market. There is no shared destiny, everybody for themselves, every member of the family is trying to scheme more out of everybody else, not as responsible. It doesn't work. It eventually collapses. And it's very much similar idea of a sort of dysfunctional family that is happening in a dysfunctional healthcare system, everybody for themselves, and yet we know from the family structure that if everybody was for themselves, it would implode. It would not go anywhere. So that lack of clear understanding of what is the right thing to do has led us to this very complicated arrangement that we are struggling to create the right set of incentives on the part of the consumers, patients, and on the part of the producers to alter while dealing with the financial incentive that the producers have. And nobody wants to do things that eventually, at the end of the day, make less money than they had planned to receive or earn, or it may take a couple generations before they realize that the money that they used to make is not going to be there, and they go into medicine for love of it, or it's still more profitable than anything else, or alternatives, that type of thing. So the outcomes research is not very conclusive. Whether fee-for-service is better into the patient outcome or managed care. And so we're still debating and trying to figure out our way out of this rising healthcare cost that is increasingly unaffordable, in the sense that, we talked about earlier how there's an economic pie, and then the medical care is taking up bigger and bigger share of this pie, which means that everybody else in the business of education, food and shelter and entertainment and so forth and so on, travel and leisure, all are giving up part of their wealth and income to the healthcare sector, and increasingly more difficult to find jobs and good paying jobs and so forth. So it's skewing the whole arrangement of the economy. And given that although healthcare is having a larger and larger percent of the population as a labor force, nonetheless, it is contributing to the gradual demise of the middle class, as people are not getting raises, and if they do get any raise, they have to cough up a larger percentage of their annual income toward their medical care, left very little for everything else, and so therefore part of the shrinkage in the middle class in the U.S. is attributable to the rising share of the medical expenses, and that's something that is of great concern. So the managed care is, again, both supply and demand side management for care, and the whole idea is that whatever we do, we don't want to lower the population health status and patient outcomes, and that's the biggest challenge for healthcare leaders to consider. But hopefully with this short lecture you get an idea as to where we're going. Evidence is still coming in, and we have to wait a decade or so to determine whether these new arrangements are working. Affordable care organizations, alternative care organizations have had some success, but not conclusive. So we have to wait and see how many will join and sustain themselves, while consolidation continues to take place. So consolidation is anti-competitive. So we are stuck in the middle as to how much competition we need, and whether the consolidation, because the idea of consolidation is that those firms that consolidate, they can reduce costs, average cost. But the question is, will they pass on some of these cost savings to consumers in a form of a lower charges, so that the premiums can go down? If these cost savings do not translate into lower premiums, or if they do translate into lower premiums in terms of the cost to the insurance companies, but the insurance companies will add that to their profit margin as opposed to lowering the premium, is the struggle that we're dealing with. So a lot of experimentation. We've had that HMO in the 70s, 80s, that people were not satisfied because the premiums were not going down very much, and yet there were pushbacks in terms of services that the HMOs were refusing to offer, or obstacles to see specialists and so forth. So there's a lot of conflict of interest. A good example to think about is Toyota. Toyota has a very close-knit relationship with its suppliers. In fact, they send their engineers to their suppliers, I know this for a fact, to train them, educate them as to how to be very efficient, because they want them to improve the quality of the parts that they send to Toyota and also reduce prices at the same time. But they're willing to assist them, and there's some degree of harmony between the supply. They give them reliable orders, their long-term relationship. They don't jerk them around every year, dropping them and switch to somebody else and so forth. And in return, they reciprocate by putting their heart and mind, make sure the quality of the product or the parts are improved and the cost efficiencies are there. And so that Toyota can maintain global competitiveness into the quality of the product and so forth. Unfortunately, this type of harmony is greatly missing from the healthcare sector, and we have to somehow figure out to bring this harmony to the industry, as opposed to this tension, the high tension environment between insurance, the providers, and then the patients who want to make sure that they're not being taken advantage of, or they receive better care, etc., in exchange for the premiums they pay and so forth. So it's riddled with tension, and until we figure out a way to introduce harmony and calm this environment so that everybody works together, and then the patients understand that there's what I call shared destiny that will hopefully improve the quality, reduce unnecessary or unreasonable patient expectations because they trust. What is terribly missing is economics of trust among all players, patients, consumers, as well as the providers and insurance, because when people trust each other, that reduces the cost of transaction. People will shake hands and will agree that the service and advice they receive is honest and is not driven by self-motive and self-interest. And so that, unfortunately, is greatly eroded in the healthcare system in the U.S. as people are increasingly suspicious of the providers and their advice to a point that patients refuse to see specialists if they are recommended by the primary care because they're not quite sure if this was a genuine recommendation or was just like sort of giving kickbacks and kind of keeping the money in the system, that type of thing. And so that trust needs to be reconstituted in order to achieve some genuine outcomes. Otherwise, we'll be arguing for decades to come. I hope this gives you some idea of where we're going with this topic.